So tonight's speaker is Dave Bateman. Now, Dave gave me, and he's going to speak about the rapid access clinics 1 through 6 at the Prostate Cancer Centre, which is at the top of the parkade of the Rockyview Hospital. And Dave's got an interesting professional history and an interesting private life history, I guess, in terms of some of your travels and the likes, I think. So I'll leave you to fill in the details, and then you can roll right into your presentation. Dave?
Okay. I'm not used to, I used to teach at Mount Royal, so I'm used to teaching to really good-looking nursing students like all of you. But I'm not used to being filmed, so yeah, is my hair okay? Yeah. All right, so. So I'm a nurse. I've been at the Prostate Centre for about 6 months now. Before that, I managed the hospital in Canmore for a number of years. Taught at Mount Royal. My wife is also a nurse, and we have 2 boys. I live in Canmore. And we spent probably about 10 years working up on the really remote reserves for the federal government in the Northwest Territories, Alberta, and Ontario. So the fly-in ones. So that's sort of my professional background, and I have a master's in public health from the University of Glasgow in Scotland. And the personal, I guess, is I volunteer with the Red Cross, so I've been to Haiti 3 times, and I've been to the Solomon Islands and Zimbabwe and Finland. And the Haiti trips were really quite eye-opening, and they change your perspective on life, that's for sure. I've been there for a cholera epidemic, the earthquake, and then the first time was for a hurricane down there, so you see a lot. And funny enough, I wouldn't have thought about it till you mentioned it, but the first time I went down about, I don't know, 5 or 6 years ago, I was with a German mobile medical clinic, and towards the end, you start giving away all your supplies to local charities and to the local Red Cross and to the hospitals, because they really don't have very much in the way of equipment or trained staff. And we came across a box, a number of boxes with probably about 300 or 400 catheters. So for the last week that the clinic was open, I was like the catheter guy, and that's about all I did in the treatment tent. Was it just word spread, and people were coming down on the buses to have their catheters replaced. And now down there's not a lot of surgery, so for people that have benign, just enlarged prostates, they would just have catheters, but they would keep the catheter, the same one, in for about 3 months, to the point that it was starting to disintegrate. So there's a connection, I guess, that full circle I end up at the Prostate Centre. So anyway, that's it. So I'm going to try and go into my presentation here. All right. Hi. My name's Dave. I'm from the Prostate Cancer Centre. And I'm going to talk about the different RAC programs, plus some of the other educational sessions and things that we offer at the PCC. So it was founded in 1999, one of a kind, made in Calgary, success story, unique in North America. I'm not sure if it's been around as long as you guys, seeing as you said 20 years, but still a long time. I just have to get my cheat notes now, in case you ask me any questions that I don't know the answer to. And I just put this on because sort of the motto is, that we're looking after one man at a time until we deal with everybody, all the males in Alberta. This is where it's located, on the 6th floor of the parkade at the Rockyview, and it's also with the Southern Alberta Institute of Urology. I don't know, I'm sure many of you have probably been to one of the urologists there or to the PCC itself, and that's very important. That's my office right there. And when we look at the numbers, I didn't go all the way back to 2003, I think, is when they had the original, they started collecting this kind of data. But if you look, essentially it's gone up every year for the number of visits that occur there. It went down a little bit last year. I don't know why, I wasn't there. But those aren't new patients. Those are visits, right? So you often have a lot of repeat visits. People come in 2, 3, 4, men come in 2, 3, 4 times. So it's not deceiving, but you need to put it in perspective of what it really is. But it's still a lot a lot of people, I'd say. Some of the milestones for the center: they had the first Canadian Rapid Access Clinic, which I'll talk about shortly, developed the Canadian Rapid Access Clinic to treatment options, the Canadian Rapid Access to post-op care. It's an advocacy. We advocate as well for men. We do research, and that's an area that's really growing at the PCC. And the first and only Canadian mobile PSA testing. There's 2 vans now. And clinical research focused on prostate cancer. If you have any questions while we're going through, just, you don't have to put your hand up. You can just say, hey, Dave, and ask me a question, or if you want to correct me if I'm wrong here. So the RAC programs, the first thing to know is that it's not this type of rack, or that type of rack, or that type of rack, or that type of rack. Okay, so. So really it's known, the PCC started with the rapid access clinics, and that, I think Dr. Donnelly, and there was Dr. Baverstock and Kozak, some of these names I'm sure you're familiar with, realized that, men, a lot of men didn't really understand or even know that they had a prostate, and secondly, when during clinical exams or yearly checkups, when the doctors thought, well, maybe there's something odd feeling about the prostate, or if they did do a blood test, they didn't really know where to send them, or they sent them to a urologist and the man wouldn't go, or they had to drive a long way. There wasn't a lot of coordination. And my experience in healthcare with men is that men tend to avoid doctors and avoid the hospital until something happens that they actually have to confront it. And so I think this was realized, and they thought, well, you know what, if we can streamline this for men and make it easier and provide a comfortable place where they can learn about their prostate, what the PSA is, and different options that they may have, that this is a good thing. And this is, I'm sure, what the stimulus was to start this. So it started with the RAC 1 clinic, where men were referred from their family doctor, and then later from the man van. If they had their PSA done and it was at a certain level, they were informed about that, and their family doctor would send them in. And if they didn't have a family doctor, they'd be referred from the PCC to see one of the doctors if they wanted to at the clinic. So the men would come, be assessed by a doctor, history, family history, PSA, and then a digital rectal exam. And then they'd decide if they were going to be monitored for a while, or if they indeed should perhaps have a biopsy. So that's essentially what the RAC 1 is. I like to think that it's sort of a beginning place for men, when there could be potential issues with their prostate. So there we are. The RAC 1 has reduced the time it takes to establish a diagnosis of prostate cancer from 95 to 8.5 days, and it's assisted over 14,000 men. So that's a lot of guys, and I think what's important here is the 95 to 8.5 days, which to me seems that men kind of got lost in the system. Well, we'll get your PSA done, and the family doctor will get the value, and then we'll send you off to a urologist, but you don't know if you got lost in the cracks or what's going on. And if we don't follow up on those things and be advocate for ourselves sometimes, then nothing happens. You go back to the doctor 2 years later, have your PSA done, and it's a little higher, and then you're going through the same thing again. So essentially, that's what the RAC 1 clinic is to do there. That's Harry, I think, isn't it? Some people here must know Harry. Ripley? Yeah. It must be taken years ago, when he was younger. RAC 2. I'm involved with Louise. I work on this program. And this is essentially after a man's come through with RAC 1, the urologist says, you know what, I think it'd probably be beneficial for you to have a biopsy. The man comes in, has the biopsy, and if indeed, based on the gland size, the PSA value, the staging, so, the clinical staging of whether or not they feel a lump or not, or nodules, and the biopsy, and determining what kind of cancer cells there are on the Gleason score, they're invited to come to one of these sessions. And just like you were saying, the idea is just to provide as much information for people in a very calm, atmosphere so that they can take it in and make their own decisions. That's essentially what the RAC2 is for at the center. And there's a medical oncologist, a surgeon, and radiation oncologist as well. And so they come in and they give a talk. One of the volunteers usually talks for about 5 minutes or so about their experience, the kinds of things to think about when the doctors are talking. And usually myself or Louise are there at the beginning introducing people, because if they end up going through a surgical approach, they're going to end up meeting me somewhere down the road. And so it's nice if you can actually establish a rapport or put a face to the name that, or to the PCC if you're going to be coming in to have some care. So at these talks, they talk about the staging, and they talk about the various options, whether it's cryosurgery, where they freeze the prostate, or if it's radical prostatectomy, where they make a large incision in your abdomen and take it out manually, or if it's robotic, where they do the same thing but with a robot, and so it's a smaller incision in your abdomen, usually just about big enough to get the prostate out, depending on how big the prostate is, so it's different for different guys. Yeah?
I understand, the RAP 1, RAP 2, the minimum height, and then all the services. I'd like to know, do you or where can you find translation service? Like, some foreigner coming in, how can you handle it?
Well, I know that information about probably RAC 1, 2, and 3, let's say, and the PCC has been translated into Chinese. I know that. And when I was going through some of the old slides from the previous presentation, there was a slide in there saying that they were working on, translated into, Spanish, Portuguese, and some different languages. I don't think that ever happened, and I'm, unless you know something about it here that I don't. So as far as that goes, I'm not sure. I do know that Alberta Health Services has a translation service themselves. Now, whether or not that could be utilized for the PCC, because we're nonprofit, I'm not sure, but it certainly could be. I would think if you're seeing one of the urologists in the Southern Alberta Institute of Urology, because they are much more aligned with AHS, and because if you're picking a therapy that's going to be in an AHS facility, I would think that would be an option. So.
Yeah, my suggestion is that contact the Prostate Cancer Society in Vancouver. There's a large Chinese population there, so the article wasn't translated over there.
Yeah, that's a good point. And another, to build on that is, I think, we can always do better at working with other organizations that do the same thing, as or overlap with a lot of the same things, and just, I don't want to say steal each other's stuff, but certainly borrow it and incorporate it into our own programs. I think that's a good thing, because in the end of the day, anything that helps and makes it easier for people is better, right? So. Right, so the men come to that. It's about 2.5 hours long, and we offer refreshments, and they usually bring a partner with them. And it's really quite open, and I've been around healthcare a lot, and I'm actually really impressed by the way the doctors talk openly about all the different therapies. There's no self-promoting, there's none of this, well, I wouldn't do this therapy, I'd do this therapy. They're very, very open about the choices and the kinds of things you need to think about dependent on the course you're going to take. So I think it's very good. And for the most part, the men that come in by the end are actually asking questions, and which to me is also nice to see. That I think because of the atmosphere that's in there, they feel a little more comfortable asking some of the questions. Because the biggest ones that come up are, of course, erectile dysfunction and bladder control. Those are the two ones that all men seem to worry about to a greater or lesser degree. And depending on the order, often it's age. So, RAC 3. This is Louise. She gave the talk a number of years ago, I guess, when before. And this is another program that we have, and I manage this, and Louise helps me. It used to be her bailiwick, but now it's mine. So any men that choose surgery, so if they have cryotherapy where they freeze the prostate, or they have robotic surgery, or they have radical open, they will see me. So they'll come to a pre-op clinic where they learn about Kegel exercises and what to expect when they're in the hospital. I usually stick my head in there and say hi because I know I'm going to see them the day or two after surgery. And then after their surgery, I'll meet them in the hospital, talk a little bit about what to expect, as far as exercise and, blood in the catheter bag, constipation, all that kind of thing. And I make an appointment for them to come in and have their staples out and then their catheter out maybe 14 days later. For the cryosurgery patients, it's anywhere from 10 days to 4 weeks sometimes before they get their suprapubic catheter out, which is the catheter that goes through the abdomen into the bladder, as opposed to through the penis into the bladder. And because they take longer, we usually, me or Louise, will follow up with them 7 days later, and then 14 days later, and then 21 days later, just to see how they're doing. And often, men that choose that kind of the cryotherapy tend to be older or have health conditions that would not allow them to be put out with the conventional anesthetic machine, because it's all done spinal through their back. So sometimes when people are older, not everybody, but sometimes we don't remember things as well as when we're younger, and so it's good to follow up with those guys, because there's a bit of a knack to turning the tap on and off when you're measuring your urine output. So I didn't really go into that in too much detail. People can ask me later, but and so when they come into the center, we offer them counseling on erectile dysfunction, incontinence, even how to change the pads, information on make sure that they don't get infection, Kegel exercises, and it seems that about 9 out of 10 men, even though they are told about Kegel exercises before they have their surgery, when they see me after the surgery and I say, well, have you been practicing your Kegel exercises? What's that? Well, do you have a wife? Yes. Do you have any children? Yes. Talk to your wife. But it is, it's one thing and that's one of the reasons I started going into the pre-op classes more, is to stress that, because it's really important to know that muscle that opens and closes your bladder. So, as I'm sure a lot of you here realize. So. Rapid access clinic number 4. This is in follow-up to after people have seen me or Louise after their surgery. There's a nurse, Heather, and she follows up with every man that comes through for surgery at a 3-month interval and a 9-month interval. So when they come into the pre-op, they fill out questions about their exercise, erection issues, if they have any, and bladder control. And then they come back 3 months later and they're assessed by Heather, and they fill out another form to see where they stand from where they were pre-op to where they are 3 months afterwards. Most men, probably 8 or 9 out of 10, are still having issues with dribbling or slight incontinence at that time. So, it's a realistic thing and a good thing, I think, to follow up after 3 months, because it gives us a lot of information on how men are getting better and how psychologically they're dealing with any of the issues going on. And at that time, Heather has a chance to talk to them further about options for erectile dysfunction and bladder incontinence. So we have like a physiotherapist that they can be referred to. We have sessions on different options for erectile dysfunction that they can be referred to. And we work closely with psychologists at the Tom Baker for the emotional support about intimacy and that kind of thing. We'll have a little bit more on some of those programs. So the 9-month, so this program, RAC 4, where they follow up post-surgery, started off seeing all the men at 3 months. And I think Heather has just finished in the last month or two the start of following up all the men 9 months afterwards. So we don't really have any data on that, other than we've just gotten to that point where we follow people after 9 months. So what that's going to show up afterwards, I'm not sure, but it's all good stuff. You know, it's not research in the sense of real research with pharmaceutical companies and stuff. It's research done to make sure that men travel through the system in the best and most efficient way that they can, and to address the issues and problems. So, any questions on rack 4? Don't worry, we only go up to rack 28. So, rack 5 is the clinic for patients who are diagnosed with cancer but don't require treatment. And I noticed that in one, I think it was the last digital examiner you had, there was an article on active surveillance in there. And so I went on the internet, like Dr. Google, like everyone else does in here. So I'm an expert on it now. And that was a joke. But, you know, I wasn't sure if that was going to come up or not. But active surveillance, of course, is there's a few doctors that we have clinics where men come in where they're being followed with clinical, like digital examinations, their history, you know, height, weight, how are their vital signs, what's their PSA like. So these are men that, you know, have prostate cancer but aren't necessarily in the category where they need to choose an option right now. And that's there's probably an awful lot of discussion about the best way to approach that. And again, it comes down to information and making decisions that are appropriate for your age, you know, your lifestyle, and your risk factors and all that kind of thing. And, you know, it's probably very easy to say, well, if you have cancer, the best thing to do is just deal with it and cut it out. But the reality is that some prostate cancers can be so slow growing and take so long before they become, you know, life-threatening, that if you're 70 or 75, the chances are that something is going to happen to you and you're going to exit before the cancer from the prostate gets you. It's going to be a heart attack or, you know, a stroke or something else. And there are side effects and lingering problems that can happen after any kind of prostate therapy. So you have to balance those, right? But if you're 40, I don't know, you know, I mean, and that's, I think, where the dilemma comes in, where people really have to be informed to make decisions. And as well, I'll go out on a limb here and say that there's certain insurance companies and organizations that have a vested interest in promoting surgery and that kind of thing because they can make a profit from it. And that's just a reality. You know, healthcare is no different in that respect than many other businesses. So that's what the rack 5 is. Rack 6 is the new one. And what it is people that are men that are on hormone deprivation therapy. And they're on injections it's usually every 3 or 6 months, I think, depending on who the doctor is. So we offer a course, Androgen Deprivation Therapy. It's a session for men that are taking the hormone blocking medications. And it's a support group, and there's a workbook with it, and you come in with your wife. It's a couple hours long, and then there's follow-ups every 3 or 4 months, you know, depending when we can get all the professionals together. And that's a little different. It's sort of in conjunction with the the rack 6. So the rack 6 is actually more the medical therapy, where you're followed by 1 or 2 or 3 of the doctors in the clinic or from the SAIU that come over and ensure that, you know, just to monitor you while you're getting the shots. It was felt that it was something that was really needed. So that's a new one that has just started up probably in the last month or 2. And the book here is by Lauren Walker and John Robinson. I don't know who Richard Wasserberg is, but I have met Lauren Walker and John Robinson. People may know who they are from the Tom Baker. And this book, eh?
How's it spelled? I can't see.
The first one's
Wassersug?
Wassersug. Yeah. Walker and Robinson.
He's a Canadian specialist, I believe, on erectile dysfunction.
Okay.
From the Maritimes. But I do
There we go.
He's now a resident in Vancouver, at the Vancouver Prostate Centre.
Okay.
And his presentation to us maybe 2 years ago is the second highest viewed presentation of any of our videos.
Well, for two reasons. He's either an engaging speaker or it's a very important problem to men, topic for men, right? So, or both. But it's a good manual. I've read through it. It's sort of it gives you a lot of information, and it's a workbook at the same time, and it's to be utilized, by singles or couples. We have Dr. Lee at the PCC from the SAIU that comes over and he does the talk with Walker and Robinson. So I just put that book in there. It's not really part of the RAC 6 when men are getting the injections, but it's sort of an adjunct therapy that goes along with it. And you have trained, dedicated staff. That's from the Rabbi Bernstein dinner. And that would be, if people, the mouse doesn't work up there, right? Okay, so never mind. I won't go into that. We also offer, it's not really us, but EFW does the biopsies at the PCC, and they're done on Tuesdays and Thursdays, and it's generally a result of coming into RAC 1, and if it's decided that you need a biopsy, then there's a referral sent out, and you're followed by one of the urologists from the SAIU, and you come in and have a biopsy, and then you have a follow-up with them, and if indeed, then you make a decision, active surveillance, or what kind of therapy you're going to choose. And then you would end up coming to the RAC 2 talk, which was tonight at the PCC. We have a resource room. I was looking over here at your literature, and an awful lot of it is the same. So there's obviously 3 or 4 really good books about prostate, and they must be I've read 1 or 2 of them myself, but there seems to be 3 or 4 that are very popular and make the rounds with everybody. And we have the same idea where you sign books out, and I noticed that there was one signed out last year in 2013 in June, and someone still hasn't returned it. So if they're here tonight, if they could return that book. A lot of volunteers that just like here with community awareness and education. They support men. We have a help desk kind of at the front when you come in, and people are directed either to the SAIU to see the urologist or down to the PCC. So most of the counseling is done, I'd say, in the center when men come in for biopsies or for follow-up. Some of it's done by phone if men want to just have some peer counseling, and there are women that are trained for counseling and to talk to partners in case they have any questions or they have questions they don't want to ask in front of a crowd of people, let's say. And a lot of the wives actually man the help or the information desk that's out front, which is nice. So, it's nice to when you walk into a place, have someone that's interested in telling you where to go. Maybe that's not the right way to say it, because I'm told where to go quite a lot. But, to have a nice welcoming face, because it can be pretty intimidating when you're coming in to have some kind of test and you either know you have cancer and have to make a decision, or you're not sure what's going on and you're going to have to do some, find out some information and talk to people. I think it's really important to have a nice atmosphere where you feel comfortable with that. So these are a few of the other little education sessions we offer. So there's Life After Prostate. Has anyone here been to that talk? One man, the guy that sits at the front, has been to that talk. Okay. I talk quite a bit about this when men come in to see me and have their catheters out. And it's a 2-hour session about every 3 weeks. A little different in the summer, depending on the professionals we can find. And it deals with, talks about, we have a nutritionist come in, a fitness expert, we have a physiotherapist that specializes in pelvic floor exercises, such as the Kegel exercise, and usually Lauren Walker or John Robinson come over from the Baker and talk a bit about intimacy, erectile dysfunction, and options for that. Now, most men will come to this session anywhere from 3 weeks to 2 months after having their catheter out. So it's a really good time, because if you've given yourself 4 or 5 weeks and then you come to this, you may have some more specific questions or issues that you may want to talk about as far as bladder control and erectile dysfunction. But as I was saying previously, 8 or 9 men out of 10 after 3 months are still having issues with urinary incontinence or dribbling. I think it helps for men put things in perspective of that this is major surgery you've had, and you don't just bounce back and start lifting weights and going out and playing golf and hopping, back into bed with your wife or something. It takes time to get better. And I think as men, we seem to, you think that we're going to get better a lot faster. Yeah.
I was back playing golf 5 days after that procedure.
Yes, but we're not talking about the golf where you putt through the windmill. No.
No, I was had a hypothermia,
Uh-huh.
which is not available yet. I do not know why. Maybe you can fill us in on this.
No, I can't,
Why is hypo not available yet?
because I don't know anything about it. But that's not why I said it's not available here. But I can't answer your questions. I don't have enough knowledge on that. You certainly would be the exception to the rule. I think most men are 2 to 3 months before they're actually doing golf. And when you think about sports like that, where you're using the core of your body and twisting, it's important to approach that slowly. So.
I had my cruises in Toronto. I had done on a Tuesday, flew back Wednesday, and I was back golfing that weekend.
I'd say you're probably, even with that therapy, probably the exception to the rule. But anyone here who golfs, or if you know friends that golf, maybe that's an option for it. So, I think it comes down to, again, everybody's different, and so you're looking at different kinds of therapies and courses of action for, for your issues. So, but good for you.
I'm just wondering why, because nobody would tell me anything about it at that time, around here, not here.
Yeah. Well, and like I said, this is something I'll look into when I go back, because it's important for me too. I'm the new guy on the block, and you only learn so fast, right? So it's something that I'll look into. What the urologist's knowledge base is around this therapy, I don't know. So, but a good point. So I think that this is also good in the sense that it puts things into perspective for men when they come after a month or two and say, gee, I'm still having some issues. Lots of other guys are. It's okay. And here's a place where I can talk about things, and they maybe have questions that they've been putting on the fridge or something like that they can then ask. The intimacy after prostate cancer, when you're talking about Wasserberg, oh, I better edit out that I can't say his name properly. We have Dr. Lee from the SAIU, and he runs these clinics as well with Robinson and Walker. So most of the time, I'd say it's probably 6 to 9 months, or maybe even greater, until men go to couples go to this workshop. And that's because you really need to give it time. It takes a long time to get the vascular and the muscles and the nerves and everything corresponding again, because you've had major surgery and a lot of things have been cut and some things removed. So it takes quite a long time to get better. I'm sure it can be very, very discouraging. But once men and couples go to these educational sessions, they talk a lot about intimacy and affection, and alternative ways to show your affection. And then Dr. Lee talks about different therapies, whether it's, Viagra or prostaglandin injections or vacuum pumps or the penile implants. There's all sorts of different options for that, and he discusses those at that time. And of course, he's also available. The beauty about these sessions is that, again, you're with people that are going through the same issues, so that there's a support there, and you can talk amongst one another, and often amongst one another, and often at the tables, you'll have 2 or 3 couples, so that you're sitting across from people, so you're forced to talk to them, and that's a really good thing. It builds rapport. And he's also available singly as well to go see him, but you get in a lot faster if you go to the education sessions. So there's peer support. This is what I was talking about before, where you can have one-on-one counseling or just talk to one of the volunteers or phone, and we'll give out a phone number of someone that can be phoned because there always someone's on call or available to talk if people have questions. There's always people that are uncomfortable to talk in a group. I find even with some of the couples that I see post-surgery, I'll get phone calls from the wife or the husband, the next week saying, well, when he said that or when she said that, that's not really quite the way it is, and I'm going to give you my side of the story. And so it's nice to have, informal, private discussions sometimes with people. It's known for educating men about the importance of early detection needs to happen first in the community. I'm a big believer in that with public health. And that goes for everything, not just prostate awareness, but it can be hypertension, obesity, diet, exercise, immunization, anything you want to talk about out in the community. And preventative medicine is by far the best bang for your buck than dealing with things afterwards. So the Man Van, Canada's first and only mobile PSA clinic, where you can get a free blood test. And to date, that could be wrong, that number, but 4,700 men have been tested. I'm quite sure it's a lot higher than that. I think that's an old slide and I missed that sentence. Edit that out. Whoops. So we partner a lot with different community groups, such as maybe Show and Shine through the PCCN, and at the Dogs game where Dave was. And so the van goes out, and the idea is to corral men and talk them into coming in and having their PSA done. It's a good thing, and it raises awareness. So it's in-house, so within 48 hours, people are provided with the results. And, if they're high, then we phone them and, we'll counsel them about who's their family doctor, do they need a referral to the RAC 1 or to a urologist? Because it can be, I imagine quite intimidating if you don't know anything about your prostate, you don't have a family doctor, and then 2 or 3 days later you get a phone call saying, well, your PSA is elevated, take out that little wallet card we gave you and look at the different values. That would throw me for a loop as well, so I can imagine that with any man it would. Combines for Cures started a few years ago. This is another area I'm not 100% knowledgeable on, but it's more for really rural. So it's a van that can go further afield, mostly in southern Alberta, and it'll attend agricultural events, go to small towns when they're having rodeos and things like that. It's funded a lot, I think, by Agrium, and there's a few other big players that help out. And this van is different in the sense that it actually has the lab right on the van. So the Man Van that you see around town or close to town takes the blood samples, they come back and they're processed. This van can process the blood right on the van, which is nice. Now, the men don't find out right away, but I mean it's processed so that you can still have the results within 24 to 48 hours. These are the Man Van statistics for the last 4 years. So 2010, 12, and 13 were really good. I'm not sure about 2011. When I was looking at it, I know that there was an event where the PCC got into the Guinness Book of Records for the largest number of PSA tests, which, I mean, there must be worldwide competition to see who can have the largest number of PSA tests in a day. And I think when they took that number out, I think it substantially decreased. But nonetheless, it's lower for some reason, and I don't know why. So, but I think overall what you see is really a trend from 2003 up, that you see more and more men getting their PSA done on the Man Van. So I think it's a good thing. The PCC has always been doing research, but I think in the last year or two, with the present manager, it's really increased and come to the forefront. And so the research, most of it is around drugs and hormone therapy. We're also doing, but there are 1 or 2 studies that are done maybe with bladder cancer and women's urinary issues as well. Because of course, all the urologists across the hall, they don't all just do prostate, right? They do a wide range of urological issues, men and women. So when you have doctors that want to do research, they can't all just be on prostate. So if you want to have everyone on board, you have to entertain and do some other research as well. And we're also doing research with an ultrasound machine now that's higher resolution in the hopes that you can visualize the prostate better for taking biopsies. That's one of the pathologists at the Rockyview. So we now have APCARE. Does anyone here know what APCARE is? Other than just reading what it says right there. The Alberta Prostate Cancer Research Initiative. How many people here have heard of Dr. Donnelly? Probably a lot. So this is really, it's sort of a repository of men's body fluids and tissues. And there's the University Edmonton, or University of Alberta is taking part. The PCC is taking part, and I think there's somewhere in Vancouver, and there's certainly one in Ontario. So when men come in for their biopsies, they will sign a consent, fill out a bit of a history, and they will donate some of the cells from their biopsy, urine, some of them sperm, and blood. So different like red blood cells, white blood cells, that kind of thing. And I think the hope is that with this huge repository of body fluids, that you can keep doing research 5, 10, 20 years down the way. And it doesn't necessarily have to be research out of the PCC. It could be from any university anywhere, but you'd have a great big vault of all these body fluids that could assist in the research. Because you never know, there could be genetic markers that they find 10 years from now, and they say, geez, this is really good. We can tell if men are gonna, if they've got a certain genetic marker, that they're gonna get cancer. And some researcher in Berlin says, well, I've got a great idea. Why don't we test these guys that gave their blood sample 15 years ago at the PCC, and they ended up getting cancer 10 years later. Why don't we see if we can find that gene marker in them and compare it to the guys now? And it may give them an idea of, you know, if you're going to develop prostate cancer. So it's a good thing, and I think it's a sort of a thinking forward for doing research in the future. And this is just new. It's just sort of getting up and running and starting now.
How long?
Yeah.
How much involvement we're talking about? One shot deal or?
Pardon me?
How much involvement it will be, like a one shot deal or 6 months, 1 year?
I think with the APCARE, I could be wrong, but I believe that it's just a one-shot deal for providing the samples.
No.
No, ongoing. I'm in active surveillance, and every 6 months I'm requested to make these contributions.
Have they? Yes, but have they talked to you? That's in the active surveillance with Dr. Heinemann. But have they talked to you about? Pardon me? With Donnelly. But have they talked to you about that specific program, APCARE? Because I know that they collect they follow that with active surveillance, but the APCARE, I believe, is a separate research thing that's going on. Same kind of idea, but much more comprehensive. The Prostate Cancer Centre is a not-profit organization that relies totally on the generosity of donors, and this is the new donors wall. Probably can't see everyone in there, but it's businesses and individuals that have helped substantially over the years to get the programs up and running. So I think I'm down to pretty well the last slide here. Hundreds of men have participated in clinical trials through our research department. State-of-the-art audiovisual teleconferencing equipment enables physicians to reach out to other urban locations, and that's an interesting thing. There's a lot of men that maybe there's no prostate groups such as yours or ours in smaller towns that maybe do have a hospital, but they don't have an active support network. So for example, things like the RAC2 talk that's going on tonight, if we can video conference in with smaller centers like Vulcan, something like that, so people can sit in a boardroom in the hospital and actually see the talk, that is good. We also utilize it for discussing, well, I don't, but the urologists use it for discussing difficult cases, or if they want to talk to an oncologist and Dr. Donnelly and then a surgeon to find out what course of action is good for a patient that has maybe advanced prostate cancer or they're not quite sure what to do. So everyone video conferences together, and you can have 4 or 5 sites discussing a case. And it's really quite interesting to watch because the talk is way up here for me. So it means that these guys really know what they're talking about. Petitioned the Alberta government, so PSA testing as of 2011, men no longer have to pay for the PSA test, which is good. Currently petitioning the government to ensure that any man who's been treated for prostate cancer can have access to erectile dysfunction aids, and they'll be covered by Alberta Healthcare, or presumably Blue Cross, I would guess. We have a Twitter site Twitter launched in September, and we have a Facebook. I don't know if we have 25 people a day do hits on ours, and if they do, it's probably all the staff just going in and hitting it. So, and that's it. I think that's Kelly Rudy, the goalie. Is that right? Okay, I had no idea. So questions? Don't make them really, really too in-depth for me.
Simple. Where is the prostate wall? The slide before this?
Oh, the donor wall? Are you familiar with the 6th floor over on the Rockyview?
Oh, yeah.
Yeah, so when you're walking down the floor, down the alley, the alley, that's bad, eh? When you're walking down the corridor, on the right is the corridor that goes down to all the urologist's office. If you just continue on going to the PCC, it's brand new. It's only been up there 2 or 3 months, and it's right on the wall outside. I could answer that one. That's good. No more questions.
I got a question about the man bed and the complex cures truck.
Yeah.
Are they more or less intended for people or men that have never been diagnosed with cancer, or can a person that's been diagnosed use that facility as well?
Well, I think both of the vans are meant to increase awareness and get men tested, right? Whether it's the first time or not.
So if I was to go to the man van, I've been diagnosed with prostate cancer and wanted to just get my PSA test.
Yeah, good question.
Would I be allowed to do that?
It seems like we're going to refer that to Dave in the back just to see if he knows, because I, of course, know the answer, but I want to test Dave.
Well, if you're currently seeing a urologist or you've ever seen a urologist for prostate cancer, the man van won't test your PSA.
What are the complex cures?
Same thing.
So they won't.
No, they won't. So the idea being is that PCC doesn't want to muddy the waters by you getting a PSA test, going to your doctor, and then the urologist who's perhaps treating you coming back and saying, you know, what's going on here? Why are you being tested? Why is PCC testing you when in fact you're under care?
So we don't want to wait 6 months and want to do one in 3 months.
Then you simply ask your doctor to give you a lab requisition and do it that way. Yeah, the urologist. This is not me talking. This is the urologist saying, don't have men tested in the vans that are currently seeing a urologist now or have never seen a urologist.
Is your question revolve around if you know that you have prostate cancer and you just want to get your PSA done in the man van because you happen to be at the rodeo, can you go in and have it done?
Kind of.
Is that, I don't know the answer to that, but presumably if you wanted to have it done, you could just, as Dave said, go to your family doctor, get a requisition and go in and have it done. There'd be no time lag or wait, for something like that. I mean, to go to your local lab, you may have to wait in line, but it would be less than a week and they'd have the results anyway. So.
I've got another question. I don't see a whole lot of difference between RAC 2 and RAC 5. They seem a lot similar in what they intended to do.
No, they're quite different. RAC 2 would be if you came in and had a biopsy, and the urologist says, you know what, your PSA is very high, we've done the biopsy, you have prostate cancer, we need to make a decision about what to do. So the man and his support person would come to a RAC 2 talk where they talk about staging, Gleason scores, PSA, and there's also a surgeon there, and a medical oncologist and radiation doc. So they're talking about, and they do talk about active surveillance as well. So they do talk about the different options that you have, one of them being to deal with the prostate cancer and the other to be active surveillance. The RAC 5 is just the active surveillance where they just monitor you. So you would go to RAC 5, you could choose RAC 5 after you had done RAC 2, let's say, as an option. So you go to RAC 2, you either say, well, I'm just going to go into active surveillance, or no, you know what, I want to have surgery. Yes?
Stuart came to us with some statistics about 2-3 months ago that there are approximately 1,200 men a year diagnosed with prostate cancer in Calgary, or the Calgary catchment area. But then only 400 of them go to RAC 2. Mm-hmm. Now, is that an issue of referrals, or is that an issue of compliance?
I'd say it's a little bit of both. There are, and there are also men that go to urologists and just make a decision about what therapy they want to have done. There are people that go to doctors, and we all know how many people here have taken pills from a doctor that, well, take this pill, it's important, you need to take it. Okay. And you go away and you take the pill. That same attitude can go on with going to see the doctor and making decisions about, surgery and prostate cancer. Same thing. The doctor tells you what to do. Pretty well all the urologists at they all refer, at the Rockyview. So, I'm not sure how that would work. Not all men that have an elevated PSA, if it's elevated through their family doctor, maybe they choose to just deal with their family doctor and they don't even go for a referral or ask for a referral. I'm just trying to think of reasons why that would be. Yeah.
I'm the facilitator for the active surveillance and newly diagnosed group. And almost every month, I'm getting somebody coming here who's being diagnosed and has not heard of RAC 2, and I direct them to RAC 2. Mm-hmm. So, my concern is, how do we enhance the numbers that are getting to...
Well, there's two parts to that question. Is the man referred to a urologist after they get their PSA done through with their family doctor? Like, do you know the answer to that question?
Yes, some of them have even had biopsies and they haven't been referred to RAC 2. They've come to our group because they've done lots through Google, and they come to our meeting, and we don't try to direct them as to what to do, but rather say, hey, here's where you're going to get the answers.
Well, I think the fact that we're here, you're here, we're there, is good for men that end up in that situation. Perhaps some of the issue is education with primary care networks and doctors' offices about what options are out there for men, to be referred or refer themselves and phone up the PCC and say, what kind of education sessions do you have? I'd be interested. Or how do I get in to see a urologist? Well, go back to your family doctor and ask to be referred to one. So I think that there must be a stumbling block somewhere between family medicine and the specialists and organizations like you and us would be. So again, it just comes down to education, right? Yeah.
I'm listening to this concern that's been brought up. My thought is jointly between the GP, the family physician, as well as the urologist who make the diagnosis. And so if one thing, the other person should be the person doing the referral for RAC, and somewhere in between the patient is kind of falling the crack. So is it the urologist definitely make a point of making referral to RAC 2? Or they kind of just, oh, I think it's the GP's responsibility?
Well, I don't know, but I know that there's a lot of possession, you know, with professionals across the spectrum. I think it still comes down to education, because all the urologists at the Rockyview refer, and we get a lot of referrals from a catchment area about 200 kilometers around Calgary, especially Lethbridge, Medicine Hat, Red Deer. An awful lot of men come from those areas, so clearly the word's getting out. But again, the statistics, Stuart, I don't know, where they come from, or that kind of thing, but it's obviously an issue. But if you actually look at if there were men here that went through with prostate surgery 10 or 15 years ago, and you think about your experience going through, and then think about the opportunities and options for men now and the support for men now, it's come leaps and bounds, right? So there's always ways to improve, and clearly the communication between organizations like yours and the PCC is education. And it's not just educating men, it's educating other health professionals and getting the word out there about the options for men.
Well, I must say I want to give compliments to your group, because looking at what my husband has gone through even just 2 or 3 years ago, it seems that you have closed that loop of gap of service with these rapid access clinics. So well, keep up the good work.
Well, we just all keep doing our best, right? So, I mean, it's interesting for me to come and listen, because I get educated from you guys as well, because, like I said, I'm relatively new to this, so I'm probably very good at putting my foot in my mouth tonight. So, yeah.
So, in 2007, when I was diagnosed with prostate cancer, I actually went to 7 different urologists because I didn't buy what each one was telling me. So I went back to my doctor, got another referral, went back and got another referral before I finally decided to have the hypo procedure. And today I'm very happy I did do that. I did a lot of homework on all the different procedures available out there. And I think anyone who is diagnosed with any sickness, doesn't matter what it is, do your own homework and find out, okay, so what is really going on? And that is my advice.
That's your experience, and I think you had a good outcome with that. But I think there's a trade-off too, right? That when you're dealing with medical professionals, they've gone to school for a long time, and they're medical professionals, and to go on the internet and look at all the different options. There are really good sites to go to for that, and there are also sites that are not very good, and there's some that are downright lie about things and can raise false hopes and expectations. So I think what I would say about that is to be a well-informed consumer and look at all the options, but you need to be rational and be able to have discussions about what's appropriate and what's not, So, well, it looks like it worked out well for you. So, okay. Anything else?
Well,
if he edits that down to about a 30-second talk, I'm going to be really happy.